All right, here's the final part, part 3. And now we're on to number 11 and joint management in EDS and hypermobility spectrum. So, one of the many chronic problems that patients with EDS experience and that may lead to pain but should be addressed for sure is joint injury. So a lot of patients with EDS experience a huge array of joint injuries that can lead to any number of collagen tissue problems, such as ligament strains or tears, tendon injuries or ruptures, cartilage damage and osteoarthritis, disc injuries, and even sometimes broken bones or stress fractures in the joints, muscle tears, or any other number of issues that can affect the ability to properly use joints. Um, if properly managed and quickly treated, patients have the potential to prevent these things from turning into what's considered a chronic or long-term injury, or from leading into chronic or severe pain. As with anything, of course, prevention is the best, but as with anything, um, we don't always have a choice. And so with EDS, there are often issues in what's called proprioception, and that's the perception of movement and spatial orientation of your body. And when soft tissues are weaker, even the most conscientious person in the world can not necessarily prevent every type of injury. Patients with EDS may experience injury from accidents or falls like any other person, but they may be more severe or problematic due to these problems with the soft tissues. They may also find that they experience minor or even significant joint problems from simple repetitive tasks or just activities of daily living that don't bother a typical person. Now, some of these things are even getting worse over time because we have devices and people are putting their heads down and spending so much time on those kinds of things, or more desk jobs, or people who are sitting at computers and not necessarily being aware of their posture, keeping their shoulders back, keeping their head in a good position. Some patients even experience severe joint subluxations or dislocations from just innocuous activities like opening a door or sleeping, and they wake up and they're not sure what happened. Or they may find that a small slip that might not bother a normal person actually caused a severe injury, and they may not notice it till the next day. Stuff like that. So given the unpredictability of these injuries, I think for a lot of people with EDS, especially as, if they start to experience these things, that it's important to have a plan in place to help manage these types of things, especially when they're the smaller types of joint injuries, and learning how to manage them, either by working to prevent them or to decrease their frequency, or having ways to help you, either at home or through regular visits if they occur. Of course, if there is suspicion that you may have a broken bone or a really serious tear or injury that needs medical attention, patients should always seek emergency services. And while very occasionally an injury can be helped in an emergency room, a lot of EDS dislocations and subluxations are often such that typical medical professionals are not trained to recognize them, and they're not trained to help them, and they don't know how to help. They often will just order an x-ray or something and then send them on their way, even if it's really apparent that there's a serious, like say for example, a rib poking out or something like that. So for preventative case working, like with a occupational therapy or physical therapist, working on stability and proprioception can sometimes help avoid some of the more common injuries that happen. And working with somebody to help keep your environment free and clear from things that are problematic, or to ensure that your spaces are ergonomic so that you're not having sort of repetitive strain injuries and stuff like that, and having good positioning so that you don't have overuse injuries. But when injuries do occur, having a good PT, OT, or sometimes having a great osteopath or DO who is trained in osteopathic manipulation therapy, also known as OMT, they're all professionals who can, if properly trained to work with an EDS patient, can help work on injuries. And although it is contraindicated in some forms of EDS and for some patients also do work with chiropractors, and there are some chiropractors who do train really hard to learn how to work with EDS patients and soft tissue injury. But again, like all of these things are conditional of how well do these people know and work with these types of issues. Some people also report that massage therapy can be helpful for them, and there are some massage therapists that don't just work with muscles but can help with the fascia and can help patients ensure that they can get things put back in place. Some patients learn and eventually learn how to put certain joints back in at home. It's important that you know how to do this without injuring yourself if you do that. Also, support devices such as orthotics or things like kinesiology tape can help to both prevent injury when doing activities that are high risk to joints that tend to be unstable, or to help a joint heal after an injury. It's important to know that overuse of some types of orthotics may lead to deconditioning for some joints, and some patients report reacting to adhesives on some types of kinesiology tape, or some on all types of kinesiology tape. But if they do work for you, that using them when in higher risk situations or thinking about them can be helpful. And it's important to know that experts can help you pick out orthotics that fit properly or braces that fit properly, some that maybe have more stretch to them, so that you're still using the joint but you have some support, stuff like that. In chronic injury, there's also what a group that I run talks about. There's some forms of regenerative medicine like prolotherapy, PRP, stem cell, and many other types of procedures. They're recently starting to receive some support by EDS experts for some types of tissue injuries, but it's still in investigational status, although it's becoming more and more accepted in some parts of the United States and in other parts of the world. It either requires very extensive appeals to insurance or paying out of pocket most of the time to receive these treatments, and it's important to approach it with caution since it's not yet FDA regulated. You want to find a doctor who really knows everything that's going on with you, all of the different health issues that you may have, and all of the complications that might occur, because as with anything, these things may work great for some people, may have contraindications for others, and you want a doctor who is really knowledgeable about those kinds of things. And so there are some patients that these things have worked really well for, and then surgery is a final option that some patients eventually just have no choice and they have to resort to surgery. It's important, though, that if a patient ends up needing surgery, it's good to have established protocols and good knowledge of what your risks are, whether they're just general risks based on EDS, whether they're familial risks, or whether you've had surgeries before and you know what risks are. So for example, knowing about soft tissue weakness, any cardiovascular issues you may have, if you have any bleeding issues, any skin or scarring issues that you may have, and any other like allergies or comorbid features, so that when necessary, surgery is done as safely as possible. And again, like as mentioned before, anesthesia can sometimes be problematic, and whether it's having problems and it giving you issues of not metabolizing properly, metabolizing too quickly, you do not want to wake up during the middle of a joint surgery. So that is joint issues. Number 12, pain management. So pain in EDS can be incredibly complicated, and pain management can vary wildly by regulations and policies within where you live, whether it's your state, your country, anything like that, and even within your own clinics, even if the policies might vary by state or country. And doctors, just their own ideas and practices that may be either more rigid or whatever. Since EDS is a connective tissue disorder, injuries are really common and can occur in the soft tissues, but also can lead to or co-occur with other issues very commonly, such as neuropathy, CRPS, fibromyalgia, migraines, headaches, CCI, Chiari malformation, or any other localized injuries as well that can often go overlooked in chronic pain patients, even and including dislocations, subluxations, sprains, or even fractures. So all of the above can sometimes be mitigated by treatment of or exacerbated by problems with other features of the disorder, such as things that we've mentioned before: dysautonomia, mast cell activation syndrome, GI issues, and other things that we haven't mentioned yet, but we will, things like mind-body work or health psychology. So that's why pain can be so complicated, just can be so variable in different people. So despite the many interactions of other features, palliative care does remain pretty important for people, including the diagnosis and treatment of the underlying injuries, as well as reasonable plans for pain management in some patients. In fact, in many patients who must deal with severe acute or possibly chronic intractable pain with the disorder. And there are numerous treatment modalities that include both drug and non-drug therapies that can be incredibly helpful for individually tailored plans for pain management, and a plan that works for each unique patient based on what their genetics are, what their needs are, all of those kinds of things. But I think one of the most important things is that pain can really be minimized in people with EDS and with these sort of medically complex yet invisible disorders, where people can even learn to start to suppress their expression of pain because it's so severe and it's been going on for so long. Yet at the same time, there's also this, well, you don't really look sick, you don't look that bad, and it just can turn into a nightmarish scenario where patients start to fear doctors and getting accused. You really want to, this one pain expert, Dr. Chopra, has recommended that EDS patients try to stay away from doctors who are suggesting that pain is only in a patient's head. Now, we are going to talk about mind-body stuff, but I want to be clear that it is, if you're in pain, you still may need help on that physical pain. And acknowledging mind-body doesn't mean that we're not acknowledging it. It just means that it can be helpful, but it doesn't mean that we ignore trying to take care of patients who are suffering in pain. All right, number 13, sleep problems. So sleep problems are pretty highly reported in EDS patients, and they often report problems like difficulty sleeping enough, waking during the night, difficulty falling asleep, problems with restful sleep, difficulty waking up, and great amounts of fatigue during the day, as well as plenty of clinical problems. Like things like sleep apnea are really a pretty common clinical problem that can get reported. Pain is a big issue for disruptions in sleep, and when it's not well managed, patients often wake up due to these problems. Patients also can have issues due to many of the other problems, such as dysautonomia and adrenaline rushes from that, waking them up during the night, allergic reactions, causing breathing problems and mast cell reactions waking them up during the night, and many of the other comorbidities that we've talked about. When the problems leading to the sleep disorder can be identified and then treated, treating those conditions with a prevention model is the best approach. But many patients end up relying on sleep medications, and then they'll find that they have metabolization problems or other issues that can lead to fast dependence and decreased efficacy over time, or can lead to other problems just with reactions to the medications. So it's important to watch for it and try sleep hygiene whenever possible. I know it's not always possible, and some of that's easier said than done. Now, with physical breathing issues, and when we talked about the TMJ and oral mandibular things and the small bite, all that kind of stuff, the high narrow palate in particular, and soft tissue problems in the mouth and throat that exist, it makes it a perfect storm for a very particular type of obstructive sleep apnea in EDS. It's a version of sleep apnea that can get worse over time and does not necessarily require a person to be overweight to develop it as they age. What happens is that the high narrow palate and the palate and uvula in the back of the throat start to get weaker, and the tissues start to droop over time, and as that happens, as those tissues get weaker, it creates this perfect storm of the upper back of the throat becoming more narrow and more obstructed, and it can start to cause more and more problems in EDS, and they can have rapidly deteriorating restful sleep. It can cause them to gain weight in some patients, develop more severe symptoms, develop issues with their heart and blood pressure, cause more problems with breathing obstructions. It's important to note as well that some patients do well with a CPAP or a BiPAP, which are very common portable machines that can assist with nighttime breathing during sleep. And so if that works, that is a really great way to help with breathing if you need it. Other patients fail being able to sleep using these, and it doesn't quite cut it if it's too severe. So due to the soft tissue weakness, it's important that patients with EDS are aware that with these soft tissue weakness problems, that the dental implements that are usually used for two reasons are often a big risk in EDS. For one, they will either cause or exacerbate if the person has TMJ, because the goal of a dental implement is to push the jaw forward. So if you already have a weakness here in your soft tissues, suddenly you can start developing extremely painful, problematic symptoms that can lead to more dental problems, and that's something that you may want to avoid. And so a lot of the ear, nose, and throat doctors that do work on obstructive sleep apnea, they often will want to, for EDS patients who do have this perfect storm of upper sleep apnea, especially since the problem is not rooted in the tongue and the lower mouth for patients who have this upper airway obstruction, they want to skip the dental implement and go to what's called a UPPP surgery if the patient has failed using a CPAP or BiPAP. And it is a surgery that tends to be very hit or miss in terms of whether it helps or not, and it is a risk because it's a surgery, but the success rates in the EDS population that has this high narrow palate are actually far higher than the success rates for the normal population getting this surgery who have that lower tongue-related sleep apnea. And so, regardless of the chosen course, it's incredibly important to treat sleep apnea. The loss of restful sleep can cause so many cascading and rippling problems and make a lot of your other health problems a lot worse. All right, so we're at number 14. We're getting to the end here. And this one is just more a commentary of, all right, what are some other very common comorbidities and or misdiagnoses that can occur? And so I'm not going to comment on how often are things comorbidities versus misdiagnoses. I'm just going to say that I think we just don't know which things are often co-occur with EDS versus are mislabeled as EDS because they never thought it was a genetic disorder prior. But before people are diagnosed with EDS, it's not uncommon for them to go through just a whole slew of other diagnoses and either be diagnosed with another systemic condition or not diagnosed with anything helpful at all. It's important to understand that people with EDS can meet the criteria or test positive for some of the disorders because they're not necessarily mutually exclusive. So some people with EDS truly also could have manifestations of other disorders, but sometimes they may or may not be helped by standard care and treatments for these disorders. Or sometimes they require non-standard care and patient-centered individualized treatments. So occasionally the disorders are misdiagnoses and provide misleading evidence for doctors that can help them make them go down the wrong path for helping patients. A good way to figure out whether a person truly has a co-occurring systemic disorder once properly diagnosed with EDS is to start treating the EDS symptoms as best as you can and the comorbid disorders, as well as the associated symptoms and injuries. And if you still have chronic symptoms of the other disorder and are helped by the treatments of that disorder, then it is likely that you have both EDS and another systemic disorder. However, if you find that all the tests and symptoms are becoming negative once your EDS and comorbid symptoms and conditions start being treated, then it could have just been a red herring diagnosis and you may not want to continue to spend a lot of time on it. It's important to consult with a specialist on this to ensure that your chart has the proper information so that you get the treatment that you need rather than continuing to see doctors who will get confused by having too many confounding disorders. Another important factor in some of these disorders is that they can sometimes mimic or even exacerbate or worsen EDS symptoms. One of the biggest disorders that can do this is Lyme disease. So, just as an example, Lyme is incredibly prevalent where I live, and it is in many other states in the country, and it is in many countries around the world. But it is very underdiagnosed in most places. I don't know of any reports of the International Lyme Association saying, oh, this area has really top-notch recognition of Lyme disease. For the most part, just like with EDS, Lyme is incredibly underdiagnosed. And it can, in some severe cases, attack the soft tissues. But with proper testing and treatment, people can heal. The thing is EDS being as prevalent as it is, and hypermobility spectrum disorder being as prevalent as it is, many people with these conditions end up getting Lyme disease as well. And when they have other disorders such as dysautonomia, mast cell, GI disorders that go untreated, it can tax the immune system greatly, and it can be incredibly difficult, especially for people with EDS and these other comorbidities, to fight off Lyme disease with proper support and treatment around all the things that they have going on. So, and then it can get even worse if Lyme crosses the blood-brain barrier and starts to cause neurological symptoms, which already are a risk in Ehlers-Danlos syndrome. So this can affect healing, mental state, and make all the symptoms worse. It can increase pain and can even make some helpful treatments that people might seek out for their conditions contraindicated until the Lyme infection clears. So if you suspect that you may have Lyme or some other major infections, I think it's really important that you get these things checked out. And it's important to have it treated as soon as possible. There are a lot of other conditions too that often sort of mimic and mirror EDS, things like fibromyalgia, chronic fatigue syndrome, MS, lupus. A lot of people with EDS end up with a lot of these types of diagnoses. Sometimes they have them, sometimes they don't. Sometimes they test positive for markers of these things, sometimes they don't. And so just being aware of these things and how commonly people with EDS get diagnosed with them, I think it can be helpful. Now, number 15, our last thing that we're going to address here is mental health and psychosocial support. And now, this is one that I just think is imperative to address. And I think it is really important to go into this because of the stigma that often surrounds and triggers people with Ehlers-Danlos syndrome, because for many years, people who are suffering with a chronic illness, an invisible disability, physical condition, can feel very triggered by being told that they may have a mental health issue, or it even being suggested to them that getting mental health support, psychological support, and things like that would help them. And I think a lot of this stems from the fact that their physical health symptoms have gotten dismissed for so many years. So I want to recognize this with a lot of sensitivity, but also by just starting with saying that there is no good reason to stigmatize mental health disorders or to stigmatize getting mental health and psychological support and psychosocial support, because it is important for everybody, and there is nothing wrong with having mental health issues and needing support. And so sometimes when we have an issue that has been dismissed for so long, we can have a knee-jerk reaction to having it suggested that we may need mental health support. But I think it's important to note that people with EDS can have the entire spectrum of psychological and psychiatric disorders that occur in the general population, and it's so important not to stigmatize these, as all patients should be able to safely seek and receive proper treatment without fear of such stigma. So that's it. It's also important to acknowledge that, as with any medical or physical disorder, especially a very painful disorder associated with chronic illness, that health psychology and mindfulness can provide really helpful tools to assist with the coping of the pain and symptoms of the disorder. So all of that being said, since the disorder is both genetic and many of the co-occurring symptoms and related injuries are complex, they interact, they're difficult to manage, and occasionally there can be a propensity for EDS patients to be overlabeled with somatic disorders or other psychiatric disorders at times when they don't reflect the truth of what's going on behind the real physical symptoms that patients are experiencing. It's extremely important that there's a balance when psychological support is employed in a care provision plan, that the care plan includes complete and comprehensive acknowledgement, differential diagnosis, and treatment of the many complex and seldom understood physical disorders that patients are experiencing. So patients often wait a very long time for diagnosis, have difficulty getting and finding appropriate referrals. They have to see doctors in far more specialties than is typical for most disorders, and they have difficulty finding knowledgeable doctors for the disorders. They have difficulty finding doctors who understand the complexity of the interactions of the multiple disorders. They often have to negotiate healthcare systems, often while also negotiating with uncooperative insurance systems. They do all of this while also sometimes being chronically severely ill and chronic pain, and sometimes while disabled or not fully understanding themselves exactly why their bodies are reacting the way they are. And why should they? They're patients, they're not doctors. They should be getting the health care, but it doesn't always work out that way. The stress of this difficult medical journey can be daunting, and patients can be reasonably frustrated at times by not being believed or told that their symptoms are purely psychological, when they end up being serious medical conditions that do have legitimate medical treatments that can help. So it is also overwhelming to have to consider so many things for just one genetic disorder. But if we take a little time to breathe, don't panic, just take one step at a time. Consider joining a support group or maybe a few. There really are great national and international awareness groups, educational and support groups, and there are great local support groups where you can get help and advice and feel that you're not alone in this journey. So remember that although many things can be treated, as of now there is no cure. The disorder is complicated, and you often have to take one step at a time in finding both the medical and psychosocial support that you need. Choose one thing at a time, get all the information you need, and get support from people who know what you're going through. This may even include, for some people, going on disability, getting in-home support, going to a support group, joining some other type of online support group, especially during COVID, or finding a good health advocate, whether that's somebody who's knowledgeable or somebody that's close to you or somebody who's willing to learn and be supportive. Health psychology and mindfulness tools are incredibly helpful for a lot of patients who are coping with this frustrating dynamic. And while they can never fully cure or fully stop the symptoms of the multiple disorders that are being negotiated, they can sometimes help patients get by during incredibly difficult periods when challenging events are happening. Furthermore, just understand that you're not alone, and it's not reasonable to complete this journey alone. So find some help, and don't be afraid to use that help. So that's the end, and hopefully this is a helpful video for you. Again, remember that not everything will apply to you, so again, don't panic, and hopefully this resource gives you some things that help you get started. Have a good day.